I'm Dr. Holly Harris, and I am a developmental and behavioral pediatrician at the Meyer Center for Developmental Pediatrics and Autism at Texas Children's Hospital and Baylor College of Medicine. And I'm also a volunteer at Through the Roof. And I am excited to share with you tonight what you need to know about autism. I love how I was given the title, What You Need to Know About Autism. There's probably way more than you could know or need to know that I definitely won't cover all of it. But my goal is to talk about kind of the medical diagnostic definition of autism, and I think that gives us a good framework to think about how children might present or some of the things that they may struggle with, and then how we can best support our autistic friends. And I'll use both, I don't know, depending on how well-versed you are in the field of child development or autism, I'll probably use both like people first language and also identity first. So some people like to say autistic person, some people like to say person with autism. So I'll probably go back and forth because both are often used. All right, so I'll just jump right in. Because I'm a teacher at the medical school, I always have to have learning objectives so people know the intent of what I'm trying to talk about. So like I said, I want to talk about the medical and diagnostic, quote, definition of autism. The main reason to do that is to recognize how this one diagnosis can result in many different presentations. So children can look completely different. We always have the saying, if you've met one child with autism, you've met one child with autism, because everyone's a little bit different. And then we'll talk about the strategies to support our autistic friends. And so I want to start about me, though, so you'll know kind of why I have such a passion for developmental peds. So that's my brother, our awesome like corduroy matching outfits, like the classic photo. I grew up in Mississippi, and my mom, we really have one of these like every year. His name's Joe Warner, and double name, classic Southern double name, and this was us. And this was us at Christmas, but he has autism. And so that got me really interested just watching our family's journey and watching him grow up. I'm older. He's only a couple years younger than me. And we were in Mississippi back in the early 90s, where not much at all was known about autism or how to support kids with autism in various settings. So it was very interesting, and it got me, made me want to find out more about what's causing autism and how we can help, which we still don't know the answers to some of those questions. But that's why I like the work that I do. And so I'll talk a little bit about what the diagnostic definition is, and I'll be talking about the Diagnostic and Statistical Manual, or the DSM criteria, so that may be a term you may or may not have heard of. But that's actually how, as physicians, how we define autism, and the kind of the checklist that we will go through to say, okay, does this child have autism? And I'm going to kind of hone in on the DSM a little bit, because I think it's really interesting if you march out the history, and I think it helps us see why it's still very confusing, like what the diagnosis is, or why it's hard for a lot of times for families to understand, but even physicians, I think, still have a hard time, if you're not kind of specifically in this field, to really understand what autism even means. And so the third edition of this diagnostic manual was in 1980, and this is how it described autism: a pervasive lack of responsiveness to other people, deficits in language development, and unusual responses to various aspects of the environment. So that was kind of how it was defined. And then in 1994, they decided that they were going to use a label of pervasive developmental disorders, or PDD. And so autistic disorder was the main one. And so to have autistic disorder, you had to have 6 out of 12 of a list of symptoms. 2 of them had to be social interaction related. 1 had to be an impairment in communication, and 1 had to be from this list of repetitive or stereotypic behaviors. So you could have kind of a constellation of it, and you had to have those certain ones from certain categories, and you had to have 6. If you didn't quite have 6, but maybe you had 4 or 5, then you were PDD-NOS, or pervasive developmental disorder, not otherwise specified. And then if you had Asperger, you had similar symptoms, except you didn't have impairments in communication. So you could communicate clearly. You may speak on one particular topic more than others, but that was when you had Asperger. And then they decided that in 2013, never mind, we're not going to have any of those diagnoses. We're going to call everything autism spectrum, which the goal was to be more clear by doing that. But then I know, like, along the way, it has caused confusion because people who are like, well, I have Asperger's, and then, you know, physicians now say like, oh, that doesn't quote, you know, it's not a thing anymore. So now it's all autism spectrum disorder, and the definition is to have all three of the social communication difficulties. So you have to have all three under this category, and I'll show you what those are, and then 2 out of 4 restricted and repetitive behaviors. So 2 out of the 4 symptoms there. Okay. I think, you know, and some of this is opinion and kind of medical perception, but I think, I mean, even amongst those in my field, you get varied opinions. I think in some ways it's helpful, but I also think in a lot of ways we do need some type of distinction, right? Because there are kind of groups of children with autism that maybe share a little more similarities than other groups. And so, or there's a child with autism who doesn't have verbal communication. They might need an augmentative device, and that child is very different than a child who completely communicates in sentences and maybe kind of just doesn't quite know how to enter into conversation. Or so I think in some ways, and especially from a research standpoint, because I also am interested in the research, I think grouping them is not helpful. Grouping it all is not helpful because I think maybe there's different pathways depending on the different presentations, if that makes sense. Yeah, so in some ways, I don't love the blanket term, but yeah. And so this is the definition currently. So you have to have, so that A on the left, those are the reduced social communication skills. And so you have to have difficulties with social reciprocity and shared enjoyment, nonverbal communication, and making and maintaining friendships. That's how it's defined in the DSM. And we can talk about how that presents and then therefore how to help kids. And then you have 2 out of those 4 on the right. So the restricted interest or repetitive behaviors, those can be things like stereotyped or repetitive behaviors, need for sameness, highly fixated interest, or the sensory sensitivities, or either sensory seeking behaviors or a combination. So this one diagnosis can result in a broad spectrum because you can see how children can meet all the social criteria but still have, you know, degrees of variance there, and then any 2 of the 4 on the behavior side. So I think I just like to set that framework because I think it helps us think about how we can really help our autistic friends in Through the Roof. So if we think about social reciprocity and shared enjoyment. So that means that kids will have varying levels of communication. So for example, we want to know their best mode of communication. So is it verbal communication? Does the child use a device? Is it signs? Because that's going to be key to know how to best communicate with them. And I always say you want to use a lot of visual supports regardless. And these are things like we all know. I've been with you all on Sunday. We see it throughout the curriculum. Like our team is amazing. Like there's always a visual and there's always something kind of on the iPad or even just a visual for them to look at, an activity that's more visual or more tactile to kind of go along with the spoken language, because that's always going to be helpful. I think it's good for us to remember that it'll be harder for an autistic child to maybe approach us to ask for help. So sometimes giving them a prompt or asking them, you know, do you need to go to the bathroom, or kind of reminding them, they may not just readily initiate that. And language comprehension is often really challenging. So when we're speaking to them, you may, again, support by a prompt, a model, a gesture, or a visual. And so it's funny because communication difficulties are so key to autism, but that's actually not in the current definition technically. I think we fit it under this, as we conceptualize autism, we fit it under this category because you're going to have difficulties with like social back and forth if you don't have language, or if you don't have, if you have delays in language or use other modalities of communication. But it is pretty key. And like whenever at the Meyer Center, when I work with kids, I will do developmental testing, in addition to kind of going through the autism specific testing. And when I do that, I'm looking at like speech and language level, fine motor, gross motor skills, and also comparing the two. So children with autism do classically have much higher nonverbal reasoning abilities than they do verbal, like more than a 20-point difference. It's usually like statistically significant, the difference, which makes sense with how they kind of interact with the world and how just the language communication side is never going to be the strong suit for the majority of time. And then sometimes I think about, because children might not be as readily eager to kind of come up or share or show or engage, they may be prone to kind of want to do their own thing. But I think it is good for us to like try to enter in their activity that they're enjoying and to engage with them around that activity. But it's also good to recognize that sometimes social settings or like a lot of kids or busy environments could be overwhelming, and sometimes it's fine if they just need to be alone for a minute and do whatever activity that they find fun to do in isolation for a few minutes. So not like we have to be, force them into the group if they just need a minute. When it comes to nonverbal communication, so a lot of kids may not readily make eye contact. Some children do, and that's not as difficult. They just may not kind of fluidly use that eye contact with words or with gestures. And then they may not readily use other gestures like pointing, waving, and what we call traditional gestures. Sometimes I think things that can help this is to provide choices, as we often do, like with the snack box, I think is a perfect example. So provide them a choice and kind of proximal, like a lot of times they're able to reach or proximally but kind of just like distally pointing or some of those things are more challenging. And then they often don't appreciate the body language of others necessarily. That's more of a subtle social nuance or requires a lot of nonverbal communication skills. And so you may have to verbally remind them or kind of gently physically remind them not to be so close to another child, and they may have to take a step back and just not realize that the other kiddo may not want them fully in their space. All right, and then for making and maintaining friendships, I think just continuing to praise any and all efforts at shared play, or I think about too like in the lessons, at lesson participation, because a lot of when we conceptualize this category in young children, we often think about play and how do they play and how do they kind of interact with toys. Is it in a relational manner? Are they just kind of engaged with the routine? So I think thinking about ways to support them in Through the Roof would be just to encourage them in any type of way that they end up participating with the lesson that we have planned. And often like modeling, I've seen like some of the group here do such a good job. I was telling Kevin, I was like, I feel like I shouldn't be speaking to them about this because I feel like everyone here does such a great job of like some of these strategies every time I'm there on a Sunday. But even just how to respond to a peer, how to approach a peer, and then.
We do have the best buddies.
Well, yeah. It's just like it's awesome, and they just have a constant like example of how to interact with others, and so that's wonderful. And then I think that other category, the restricting repetitive behaviors, is another area where we really do have a lot of strategies already in place in Through the Roof. And so I think about because children with autism like routine, they have a bit of a need for sameness, and they also have difficulty with transitions. I have noticed every Sunday, everyone's great about 5-minute warnings, timers, visual timers, kind of having that structure up on the board where they see what time they're going to the playground. That's why those things are in place, because it's extremely helpful. And they know what to expect and to prepare for their transitions. And then I think a lot of kids do have preferred interests or maybe a fixated interest, as we would call it in the textbook. But just joining in with them in that and engaging around that. And also trying to stretch them to maybe talk about something else or engage with something else is also a good thing too. But use that kind of high interest to really connect with those kiddos. For the sensory side of things, I love the sensory activities that we have every week now, and that's huge. That's extremely helpful for them to just have some way to get their hands on something, or kind of, a lot of our kids just have sensory seeking behavior in the sense that they like to crash into the bean bags, or they like to spin around and have motion, and so there's place for that in Through the Roof and on the playground, and it's an awesome opportunity. And then some children also have sensory avoidant behaviors or sensory sensitivities. So things might get too noisy or too active in the room, and that can be stressful, or they may need to go to the sensory room where it's quieter and dim. And so just being alert to that and appreciating that for each of the kids in the room. With the stereotypies and the repetitive behaviors, they're often like not harmful. I know I've had several kiddos who were playing and you're excited and flapping, and it's not necessarily anything we need to do anything about. There are, of course, some behaviors that need to be redirected, like aggression toward others or themselves. And again, I've seen people do such an awesome job of just, okay, no, we don't hit, just simple language, kind of move them away a little bit if you need to, and just redirect. And then obviously some children at certain moments need to take a break. And then I think the staff's awesome about recognizing that too, and when they may need to step out and go to the sensory room, or be supplied with some other outlet for that when they're feeling overwhelmed. And I think my biggest take home that I've learned along the way, probably from my own experience at work and even here, is that the best way to support and serve our autistic friends is just to get to know them individually, because at the end of the day, each child with autism could have some different array of those symptoms, and most often the parent, the caregiver, the sibling, or just someone who's worked in Through the Roof a while will know some of those kind of unique things about that individual or that child. And that's why I love the group, and I love volunteering, because you can see how everyone gets to know each of the kiddos and kind of knows their favorites or the things to avoid maybe. And if you're not sure, ask someone that's working in Through the Roof that's been there a while, or I'll often ask the parents, because sometimes when I'm been there on a Sunday morning, I'll see a behavior and I'm like, well, I'm not sure if he or she's distressed when they do that behavior, or if they're excited. And so I often ask and just clarify so that I know. And then some of those things that I've talked about along the way, like mode of communication, things that they're particularly enjoy, or things that are aversive. So making sure we know those things. And I also ask parents, like, if there's a certain behavior or thing that they're working on as a family that we could support them in. So if they're really trying to work on going to the potty, I know parents are good about telling us that one, because then we can make sure that we do that. But kind of asking families, like, is there something else you're working on, a certain word or a certain strategy that we can help with, and kind of across the board, at home, at church, wherever they are, they'll be working on that. And that was honestly all the content that I had, because I wanted to open it up for questions, because I'm like, there may be some things that I didn't even talk about that people are curious about. Anything from like what we do at the Meyer Center, why our wait list is 2 years, I can't answer. And like, what is a medical diagnosis versus educational. Yes, the question was the stimming behaviors, and how it's challenging to determine, is it enjoyment, is it not, is she trying to communicate something, should we stop it, should we not? Short answer is, I agree with you, it's really challenging. I think it's always good to try the different strategies you're talking about. So present her with a question, and I don't know if you use like visual supports or if she has a way to indicate it, but kind of go through, so kind of go through those things, use the sensory outlet, try it, and then you can reassure yourself that it's not a communicative intent really, maybe. So is it, is she enjoying it? Maybe. It's also okay though in those circumstances. I tell families a lot of times, there are times when that you don't want that behavior to occur. We think about, children who have a more of a typical course of development. There's still things that they enjoy doing that you don't want them to do, or that we need to redirect, and or they need to be maybe trying to engage or attend to learning or attend to something else that you want to, I guess I hear what you're saying is like you don't want to just do that the whole time. Like maybe there's something else that she could be doing and trying to learn or do. And so that's a good reason to redirect it. So the question is like, when kids come to my center, am I seeing like certain lanes or age groups where I'm making certain diagnoses? And to your point, so the PDDOS, NOS went away with the DSM-15. So as of 2013, it's all autism. Yeah. I will say that I actually see all ages coming in, partly sometimes because they've just been on the wait list for a long time. Not that no one was concerned at an earlier age about some symptoms. I will say that a lot of times we conceptualize. So I think the children that I see that are younger do have perhaps more noticeable symptomatology. So have a greater degree of communication difficulties, maybe some more obvious, like stereotypic or repetitive behaviors, because usually people notice in the younger ages, it's usually speech delay that's prompted it, so still really not speaking by 2. In older children who come to me, a lot of times they don't present until they're older because some of the symptoms are milder. So as the social demands get higher in the grade school, people start to notice that maybe there is a little bit of a struggle with understanding and back and forth language, or some of those older children who don't come to attention until later, often you usually have more of the restricted interest repetitive behaviors, so kind of focusing on one topic or being very rigid and more of that anxiety, OCD, whereas the younger children, I feel like their behavior symptoms tend to be more the obvious, like motor stereotypies or some of the sensory driven behaviors. Yes. Okay. I'm so glad you brought this up, because this was something else I wanted to say on the slide about every individual being individual. The DSM, so the diagnostic manual does have these qualifiers. So is it autism with language impairment, autism with intellectual disability? So a lot of children will have autism and intellectual disability, and technically those are 2 different diagnoses that do run together commonly. But not every child with autism has a lower IQ. So that can be one thing that impacts the child's level of kind of participation and understanding. I know as a developmental pediatrician, I like to do my developmental testing because it tells me where the child is cognitively. So if I have a 7-year-old, I'm going to find out first, is he a 3-year-old in his kind of cognitive functioning? Because then I put all of his behavior into that context. So maybe he doesn't have autism, maybe the child just has intellectual disability, and of course their communication's delayed because they're actually 4 or 5 years delayed, just cognitively. And yes, I see a lot of kiddos with genetic syndromes. So I specifically see Fragile X, Angelman, and Phelan-McDermott syndrome, and then there's a host Rett and a host of other syndromes that, again, you have the genetic diagnosis. That's on a report from the lab. We know where it is, whereas autism is still a descriptive clinical diagnosis. So you can have both, and it's interesting because not every child that has Fragile X, for example, will have autism, but a lot of them do. And I feel like that part's muddy. I wish that, and I think it gets challenging too, because depending on whether or not you say they have autism might impact what their insurance covers and. In school. Yes, and school. You're it's really due to the Fragile X, but they probably do have those core features in some capacity, but I do feel like people maybe stretch it. I feel like in practice, we do kind of, some kids get multiple labels for a reason of hey, let's get all the support we can. My research mind, I have my clinical care brain, and then my research brain really wants to keep it distinct, because I'm I think when we're looking at it, these are different things and different causes. A lot of MDs you won't see kind of diagnosed sensory processing, but I think that there definitely are kids who have difficulties with sensory processing. And so I actually probably couldn't tell you the like key definition or what, but I think, like you said, the treatment strategies are important. And so I think you know, a lot of times I will see kids with autism also have that diagnosis, or some kids maybe just have that diagnosis. Like maybe there weren't enough of the other features and it's truly like overwhelmingly the sensory symptoms. So yeah, I think both, or sometimes one or the other. Yeah, I know when I see sensory, I mean, I do always consider like, is there something else that I'm missing that is like causing those symptoms? But sometimes they don't kind of fit in any other diagnostic bucket, if that makes sense. Yeah, I do think there's something to there's in autism. We actually have a researcher. It's a long way off, but he has like a pupil booth that's like trying to look at like pupillary response to different sensory stimuli. But I think there's something to the filtering of sensory information in autism and maybe in other neurodevelopmental conditions as well. But I know my brother, he will, when he's talking to us, he'll be like, I'm just gonna close my eyes. Because he's pretty verbal and he would have been PDD and OS or Asperger, I don't know, but he's like, I'm just gonna close my eyes because I can't, okay, now you can talk to me. Because it's too much. Like or he'll be like, I just saw something out of the corner of my eye. And I think a lot of children, like auditory, I'm working with some of the audiologists at Texas Children's because they've noticed different like auditory brainstem response to sound in children with autism than other kids. And so we're trying to quantify that because there is something about either the ability to filter the information, whether it's visual, auditory, tactile, and maybe it's difficulty attending to what's important, right? So they're in a conversation or socially, we can attend to that person and their language and their body language. But a child with autism, I think, has a lot of trouble making sense of all the other information. It's like we can drown out the background noise of the air conditioner, and I think they really can't. So vacuums, blenders, those are the classic noises that bother them. And I don't know, there's some quality to those noises, like the blow dryer, the vacuum, the blender. It's like classic. That's classically what parents tell me. Right. Yeah, so along with kind of intellectual impairment, language impairment, you can have autism with other medical or genetic diagnosis or other kind of developmental diagnosis. And they do mention like GI considerations and complications. And there's like two different, lanes of thought. So a lot of times children with autism will also have either motor incoordination or just low motor tone. And so that contributes to like certain GI issues like constipation, et cetera. Sometimes the sensory driven or even just like rigid, visually driven preferences around food, like for whatever reason, the food preferences tend to be not the foods that help you have regular bowels. They're always like the, goldfish, bread, all of that. What? Yes, exactly. Yep. And so that contributes to we do know that there's some research around like the GI bacteria being different in kids with autism. Haven't been able to figure out like chicken or egg, like was it the preferences that then molded the GI? There's a lot of interest too in, immune system. And there's an immune system and a nervous system actually in our gut too, right? So but I know there's a lot of work in the immune cells in the brain as well. So something about the immune system, because the brain's just so hard to study because you can't just go in there and draw stuff out like we can on the blood. But yeah, there's a lot of like thought around that. So there is some acknowledgement. Mm-hmm. I don't know. And this is a separate conversation too, but I love being a Christian in medicine too. And I think, especially in the neurodevelopmental field, because there's so much that we don't know. And I think a lot of people get very committed to kind of like certain thoughts within medicine. And I feel like when you're a Christian and you're like, we have a creator that's probably that is so much beyond what we can imagine, especially when it comes to the brain. I'm like, there's so much we don't know. Yeah, which makes it exciting because then you can kind of think outside the box.